Well, that was a great talk by Dr. Farah. This will be a little bit of overlap, but it'll build on that as well. So I think, first of all, this is a very heterogeneous population set as far as how they present and the timing of how long they've had symptoms for. And there's a vast array of tools to use. I think it's very, very important in these cases to involve your vascular surgeons, especially if you're at a community hospital. Prior to the 1950s, really amputation was the mainstay of treatment. The Fogarty arterial embolectomy catheter was developed in 1961 by Dr. Thomas Fogarty, and then eventually surgical bypass as well. Typically for the 2Bs and 3s, definitely the 3s, like Dr. Fair was talking about, amputation is going to be really the mainstay of treatment. For the 1 and 2As, it's usually a hybrid approach oftentimes. This is some data from the Vascular Study Group of New England in the early 2000s looking at infrainguinal bypass for ALI as well as CLI. And what you can see is that there's clearly higher morbidity and mortality for bypass surgery in ALI patients. And again, that's driven primarily by cardiac issues, heart failure, myocardial infarction. So these are very, very sick patients, and really surgical bypass should really be reserved if they failed endo. There's various endovascular techniques you can use. The percutaneous options are catheter-directed thrombolytics or thrombectomy devices, and more commonly it's a hybrid between these two. So various different catheters. There's the Unifuse, or more commonly most people use the Craig-McNamara. These are 4 or 5 French, and as you guys know, the Lytics works by converting plasminogen to plasmin, which then binds these fibrin split polymers, which, along with platelets and red blood cells, form the thrombus. And usually these people will, stay overnight, 24 to 48 hours, and then you'll bring them back and have to monitor fibrinogen levels, et cetera, in the ICU. The advantages of CDT, it's a percutaneous therapy. It's less invasive, decreases morbidity of surgery, decreases reperfusion injury because you're opening up the leg over a period of time. Not right away. And oftentimes, if you have no outflow, it can identify lesions that need to be treated, and it's applicable to subacute lesions. So these people that come in with 10, 11 days. This is a patient with a Rutherford 2A that had about 10 days of symptoms with a SFA thrombose stent. There's 3 big trials in the 1990s which really compared, they're randomized trials, they compared surgery to lytics. And these kind of helped us to understand sort of the difference between these two, and very, very sort of pivotal trials. The first was the Rochester. It was 114 patients with acute ischemia defined as less than 7 days of symptoms. They were randomized to open surgery or CDT. The results were really equivalent 12-month limb salvage, improved survival in the CDT group, driven by decreased cardiovascular mortality. The subsequent surgical procedures that these people required, they often did require surgery going forward, but it was lesser magnitude and it was performed electively. And that's a theme of all 3 of these trials. The next one was a STYLE trial. It was a randomized controlled open surgery or CDT again. The goal was to enroll 1,000 patients with non-embolic arterial or graft thrombosis. Very interestingly, in this trial, ALI was defined as 6 months of symptoms, which is, just kind of absurd. They used TPA and urokinase, and the primary endpoint was a composite of recurrent ischemia, death or major amputation, cardiopulmonary complications, or renal and vascular complications. And interestingly, it was cut short at 393 patients because they hit a clinical endpoint favoring surgery, and that was primarily driven by ongoing and recurrent ischemia. However, when they stratify these patients by those who really were ALI patients, those with less than 14 days of symptoms, there was a reduced major amputation in the CDT group versus the surgery group. There was no amputation reduction beyond 14 days in the CDT group versus the surgery group. So the conclusions were that there's a reduction in amputations for patients with less than 14 days of ischemia. Patients undergoing lytics require less extensive open procedures when surgery was required. Again, you see the theme here. Finally, there was the TOPUS trial in 1998. It was 544 patients, again, less than 14 days. It was defined as ALI. They underwent randomization with urokinase versus an operation. 1-year amputation survival was, again, similar. Interestingly, there's a higher success rate with lytics and bypass grafts. And there was less surgical interventions at 6 months in the lytics group. increased morbidity driven by bleeding complications in the lytics groups. The conclusion, again, was that lytics reduced the need for open surgical procedures with no significant increased risk of amputation or death. So typically what you'll see is these patients that undergo lytics, they may require surgery down the line, but it's going to be of a lesser magnitude, which is very, very important because it's this long anesthesia, these long bypass surgeries, and these very sick patients that lead to these cardiovascular problems down the line. So the disadvantages of CDT, the infusion time is 2 to 4 days. You may need ICU level of care. The bleeding complications with the absolute and relative contraindications of lytics, of course, and contrast and radiation exposure. So then you have percutaneous mechanical thrombectomy. Various devices to use over here, angiojet with Boston Scientific, the penumbra, which, as you know, a cardiologist, so I use that most often. Jedi is probably the oldest out of these, made by Abbott, and then Surmodics, which is the Pounce, and the Pounce LP, which is more for the tibials, which is a mechanical grab and go, kind of like a endovascular Fogarty. This is a table just comparing the different devices that we have. In general, these will most of the time go over a 7 or 8 French sheath. We use an 035 wire. The penumbra and Abbott are mechanical aspiration. The angiojet has a high velocity jet, which creates this sort of low pressure system in the catheter and creates a suction. And then the Pounce has 3 components. It's a delivery catheter, a basket wire, and it's a funnel. And the basket is delivered distal to the thrombus. It deploys 2 nitinol self-expanding baskets, and the baskets capture the clot and are retracted into a nitinol collection funnel, and oftentimes you'll use a 8 French sheath for that. There's great animations on that. There's a couple of trials here. None of these are randomized controlled trials, but there's some data showing how PMT can be used with catheter-directed lytics. This is some study from the Pearl Registry, which is a multi-center observational study, 283 patients with ALI, 83% procedural success with 52% of cases done without the need for CDT. Subgroup analysis showed significantly better outcomes in patients without infrapop involvement and those who underwent PMT without the need for CDT due to increased bleeding complications. And the results of this really show that the use of PMT is safe. It can be a first-line treatment for ALI, especially if you can get rapid perfusion to the extremity in 1 or 2 passes. This was another trial using penumbra for ALI patients. It was single center, retrospective, 33 procedures, 29 patients with 70% success rate up front with penumbra, and that was improved to 90% in those who had CDT as well. And really the predictors here of success with PMT up front was the timing from the symptom onset, so those who present very acutely, 1 or 2 days of symptoms, not those subacute patients with 10, 11, 14 with more formed clot, and a shorter treatment duration. So if you can get 1 or 2 passes, that's associated with a good outcome with PMT. The conclusions were that mechanical thrombectomy is a good first line for cases in which you can get good results with 1 or 2 passes in a short amount of time. More complex cases, extensive thrombus, those people may require CDT overnight to kind of clean up residual thrombus. You bring them back and then you kind of see what's going on. Finally, this is a single center retrospective study also using angiojet, CDT versus PMT, 49 patients, equivalent limb salvage, higher mortality in the CDT group, again driven by bleeding. And what they saw here was that greater than 150 angiojet seconds resulted in a higher rate of hematuria, acute renal failure, and death. Probably some of this was probably driven a little bit by embolization as well with the device, et cetera. So in general, you're seeing that these trials show that they're oftentimes used together. This is just a summary slide looking at the different modalities for treatment of ALI. Open thrombectomy has a definitive role here. We had a case with a per-closed closure and a young gentleman who went home 2 to 3 days later, developed symptoms, came back, extensive clot going into the external and common iliac. Tried to do a PMT, but the clot was too formed. And he had to go to the OR, and he had a aortoiliac thrombectomy with a femoral artery endarterectomy. He had a fantastic result. Surgical bypass really, that's reserved for multiple failed prior interventions. Again, these patients are very high mortality, and surgery carries a high cardiovascular mortality for these patients, for the ALI population. CDT is for extensive limb thrombosis when you have no evidence of patent outflow. The risks, again, are bleeding, embolization. And finally, PMT will be used in conjunction with CDT. It's for relatively acute thrombus, remember, for those presenting with 1 or 2 days of symptoms. Large volume thrombus, oftentimes embolic material. You got to be careful just with AKI, further embolization, so you'll watch these people afterwards very carefully. In conclusion, open surgical revascularization carries a high degree of perioperative morbidity and mortality. CDT is proven to have advantages over surgical revascularization in patients with less than 14 days of symptoms. These patients may require surgery down the line, but it'll be less extensive, less of a major surgery. PMT devices decrease the bleeding risk of lytic exposure and they shorten perfusion time. And in reality, oftentimes these devices will be used together, especially for those subacute patients. I think it's always important to involve a surgical team in decision making here. This is a surgical disease, and I think you really have to have a good surgical team and get them involved early in these cases. Thank you so much.